Hey everyone, I hope everybody's doing well. It's been a long time no see, and I hope everyone is enjoying their externships. I think it's exciting that we get to all learn all this different stuff, um, and I'm excited to watch some of your guys' case studies. So today I'm going to be presenting a little bit on post-traumatic left labyrinth concussion. So my patient today is none other than George Washington. He is 30 years old and he arrived to our clinic with chief complaints of vertigo, dizziness, and imbalance. He said on July 19th, he was camping with some friends in a yurt, and apparently he says he may have had a little too much to drink and he hit his head against the yurt. Immediately he said he felt as though he was a little imbalanced. However, he wasn't exactly sure if that was just the drinks or if it was his vestibular system. And then once he arrived home on July 21st, the patient started to experience true vertigo. So he started to feel as though the whole room was spinning with him. And he said that it would not stop, and eventually led to him throwing up. And at that point, he decided that he was going to make his way to the emergency room, and that was probably what was best for him at the time. Upon arrival at the emergency room, he was diagnosed with a left BPPV, and there he was prescribed meclizine and Zofran. Since his visit to the emergency room, he says that he continued to have episodes of vertigo and lingering imbalance. He brought this up to his primary care physician, and his physician stated just to wait about a month until going to a vestibular professional. I'm not sure if that was the best case for him. However, that is not my opinion. Or, that is my opinion. His opinion is not mine. Once he arrived to our clinic, we went through his full case history. Our appointments start over the phone actually a couple days before with a 45-minute conversation with one of the doctors so that they could get a full case history, and so that we could kind of review it before the patient comes in. Once a patient comes in for their appointment, we sit down with them for about 30 to 45 minutes again and just go over the case history that they presented us with. And we make sure that everything is correct. We make sure that there have been no changes since the phone call, because sometimes it could be like 4 days before the appointment. So we just want to make sure we dot all of our I's in that situation. With George Washington, he says that his triggers could include looking in different directions, so left to right, up and down, while walking. These include quick head movements, and especially with very stimulant visual environments, he says. His DHI score was 77, so that is considered severe. When we performed the step Fukuda test, he had a significant leftward sway. So at this point, we're already getting an idea of what is going on in his case. Next, we move on over to Temps, reflexes, OAEs, and a simple audiogram. He happened to have type A Temps bilaterally. His reflexes were elevated or absent across all test frequencies, 500 to 4K, in both ipsilateral and contralateral stimulation. However, during this day, we weren't exactly sure if that was true and accurate, just because we thought it could have been an equipment malfunction, so we did not bill for that. His OAEs were present and robust at test frequencies 1500 through 6K. So we kind of had an idea of what his audiogram, even just talking with him, would be. The pure tone audiometry showed that his right ear was completely normal. However, his left ear showed a mild, low-frequency sensorineural hearing loss. However, he didn't report it at all. He was actually a little surprised by that. After that first appointment, we then move into the computerized dynamic posturography. Here we do 3 different tests. We do SOT, MCT, and ADT. My favorite one is SOT, just because you're able to separate every system that makes up your balance system and kind of just analyze it that way, very individualized. And the other ones are just very helpful in ruling central versus peripheral pathologies. However, he did great. Everything was completely normal in his case. I think it could have been because he's young. but he wasn't showing any sort of, vestibular spinal reflex issues either. After that, we kind of move on to C-vemps. His C-vemps were obtained bilaterally. They looked beautiful and present. However, when we move on over to his O-vemps, we see that there's a reduced response in the left ear with a 40% asymmetry. Our clinic norms are actually 40% and greater, so he was right on the cusp of having no asymmetry, technically speaking. However, it would have still been reduced. This is kind of interesting to see because of his history with positive left BPPV. Typically, we see that patients who have a positive left or right BPPV, their utricle is typically weakened post incident. So that's a big part of our therapy, is kind of strengthening the utricle organ, just so that they don't still feel imbalanced and off-centered, especially when it comes to forward and back and up and down movements. Next, we move on to the epley maneuver. So his was actually interesting. We were expecting him to be positive again just because of his symptoms. He said that he still had room spinning vertigo. However, when we did the Dix Hall pike on him, he was negative for both ears. However, we did find spontaneous right beating nystagmus in both spontaneous right beating nystagmus and right horizontal gaze. So that kind of just shows that there is a left peripheral finding, not very specific. Once we move into positionals, we also see that spontaneous right beating nystagmus again, however, it's in supine. So again, just reminding us that there's some sort of peripheral finding there. His high-frequency head shake showed a right beating nystagmus that was provoked with the stimulus. And his left VNG, I don't know if you watched my other video, but we currently use the water balloon caloric system. And so, to be honest, it's not always 100% accurate, so you have to repeat a lot just to make sure that the balloon fits in the ear canal correctly. And so when I was doing his VNG, I started off with the right cool, and I said, wow, that looks beautiful. Moved over to the left cool, and I was like, wow, I really messed this one up. So I decided just to continue. I moved to right warm, again, beautiful responses, just normal young healthy adult responses. And I moved to left warm, same thing, just a really strong weakness. I don't know why that says left weakness at 100%. That is not correct. Once you take out the spontaneous beats, it's a little less. I think it comes out to like 75% weakness, but it's still a strong left unilateral weakness. It's still there, and you could clearly see it on those beats. This next test was really important to us, V-hit. We wanted to look at each individual canal, and you could clearly see that his left lateral canal has both overt and covert saccades with low gain. So that shows us that that canal is just really weak. His eyes are not following once we quickly turn his head, which kind of makes sense as to why when he's turning his head, when he's walking, he kind of feels off and imbalanced. So again, the covert and overt saccades are there. However, with the low gain, that really just supports the evidence that, yeah, there is a weakness in that canal. Lastly, we move to the rotational chair. His calibration and spontan gaze were all within normal limits, which with the spontan gaze was kind of surprising compared to his other spontan gaze. Next, we move over to sinusoidal harmonic acceleration. His gain was actually within normal limits. I wish you could see, it's like gray. It should be like a gray line here that shows what's normal and what's not. However, gain was within normal limits. Phase had a low frequency phase lead, which just means that these are above normal limits. Asymmetry was completely normal. Spectral purity was completely normal. Typically what we see with a low frequency phase leads is also low gain. That just shows to us that there again is a left peripheral finding, not a left, just any peripheral finding. However, his gain is within normal limits, so that also shows us that maybe his brain is trying to compensate. Maybe he already achieved further compensation than he was, let's say, a month prior to coming in. If he came in immediately after his hitting his head, that gain could have probably been a lot lower. So anyone who has some sort of injury or weakness will have a low frequency phase lead. It just typically comes with low gain, and compensation typically brings gain upwards back to normal. And then we have subjective visual horizontal and vertical. That's where they have little buttons on their handlebars. They're making the lines up and down and perfectly horizontal. These are within normal limits based on our clinic norms, and I wish you could see again. They're in the shaded region, which means they're normal. When we start rotating him in the unilateral centrifugation, we start rotating him at 300 degrees per second. He starts to have this leftward tilt, especially when we isolate the right ear, which is very interesting. So could just show some more weakness there. The left ear looked good. Dynamic center position looked here and there. A little leftward, actually, now that I look at it. Okay, so summary and diagnosis. In combination with a thorough case history and the objective testing, we're able to see not only the general idea of what is going on, but the specifics of where the issue is lying. Like I mentioned before, our case history is very thorough, and it's honestly a big part of our testing. We really have to listen. I'm being taught right now how to take even more in-depth case history, which is, I thought I had it down, but there's always more to learn. And then his official diagnosis was a post-traumatic left labyrinth concussion, uncompensated left peripheral vestibulopathy, left ventricular dysfunction, VOR, and OOR disturbance. So what do we do with that information? We move him into therapy. Thankfully, I work at a place that allows us to do therapy. And our treatments are kind of based around the 3 reflexes, so vestibular ocular reflex, vestibular spinal reflex, and the utricle reflex. So that kind of just breaks them all down. With George Washington's case, we needed to focus on the VOR and the OOR because the CDP showed that VSR was completely normal. He could walk, however, he's having issues with his eyes and utricle. So what we do is a lot of optokinetic training. It's typically 12 sessions. We like to see the patients just because there's a lot of studies that show that 12 sessions you should be seeing results at that time. They're about 45-minute long appointments. And essentially what you do, you have the patient start watching these lights go back and forth, kind of retraining the VOR. Eventually you move into harder surfaces, so maybe they're on foam, maybe they're on the rocker board, they're marching around. This is the Burtech machine, so we can make the floor move off of that. That's strengthening the VSR, which is also helpful. Eventually we start to incorporate some head movement, so up and down, left to right, forward and backwards. That's then going to start strengthening your utricle. So he's doing great so far. This is him. Oh my goodness. Please ignore that. So he's currently in his 8th session of therapy, and he's doing great. He has reported significant improvement since his first session. He's now able to pick things up, move things around. He's currently got a lot of life things going on, so he's a really busy guy. So it's nice to see that he's able to move boxes around and just get back to his daily life. You could also see down at the bottom his V-hit. The left lateral canal is essentially normal. Can't really see it, but there should be 2 little overt saccades that are there. However, the gain is back up to what it should be, so that's looking great. Kind of shows that the left lateral canal is healing. And then again, those lines, vertical and horizontal, are looking great. So it also shows a little bit of improvement on his otolith organ. One thing we do not do upon reassessment is the unilateral centrifugation, just because we don't want to make our patients sick. It's about 8 minutes of spinning around. So it would be interesting to see if his lines have gotten better. If you guys have any questions, that's all I have for today. If you have any questions, feel free to reach out to me. You have my email or text me or anything. Yeah, this was a really fun case. Thank you guys for listening.